Hey everyone, welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Nour, and I'm accompanied by my bestie Tala. And if you ever see us in uni with matching fits and hijabs, just know it was by accident. For today's episode, sadly we're not matching, but we have a very interesting topic. It's all about a symptom every clinician sees and every patient hates: diarrhea.
Thank you, Noor, for the wonderful introduction, but let's not make this episode about our outfits. This one is extremely high yield. Diarrhea shows up in clinics, emergency rooms, and inpatient wards. And if you do not approach it systematically, it can get overwhelming very quickly.
So today we will build this step by step. We will start with acute diarrhea, move to chronic diarrhea, and then wrap things up with some treatment modalities.
Clinically, diarrhea is defined as increased stool frequency, more than 3 times per day, along with increased liquidity. It is not just frequency, consistency matters too.
Duration is key here. Acute diarrhea lasts less than 2 weeks. Persistent diarrhea lasts 2 to 4 weeks. Chronic diarrhea is anything beyond 4 weeks.
That 4 week cutoff is important because most infectious causes should resolve by then. If they do not, we need to start thinking differently.
So, what's actually happening physiologically, Tala?
At its core, diarrhea occurs when water secretion exceeds water absorption. This can happen through 4 main mechanisms: secretory, where we have an increase in secretion; osmotic, when we have impaired absorption; inflammatory, and abnormal motility.
Clinically, one of the first questions we ask is whether the diarrhea is watery or bloody.
Watery diarrhea usually points to small bowel involvement and tends to be large volume with minimal fever. Bloody diarrhea suggests large bowel involvement, inflammation, fever, urgency, and tenesmus.
And if we're talking about bugs, do keep in mind that Entamoeba histolytica and Schistosoma species are associated with bloody diarrhea, whereas Giardia, Cryptosporidiosis, and Cyclospora cause non-bloody diarrhea.
We can also differentiate where the issue is with the symptoms our patients present with. Noor, give us a clinical scenario and let's try to see if the diarrhea is from the large or small intestine.
My pleasure. So we have the case of Pamela, a 40-year-old presenting to us large volume diarrhea associated with bloating and cramps. Stool has no occult blood or inflammatory cells. What do you think?
Classic small bowel diarrhea. Large bowel is more frequent, less volume, and associated with fever and painful bowel movements. RBCs and inflammatory cells can also be seen.
Honestly, many things can cause diarrhea. Traveler's diarrhea, for instance, is acute and due to bacterial infections. We can also see it with diabetes, where patients have altered GI motility, SIBO, and the drug side effects like metformins.
Hospitalized patients also tend to get diarrhea, usually due to C. diff, ischemic colitis, tube feeding, and again, drug side effects.
Going back to infectious causes, we can actually guess the pathogen based on the incubation period. This is very high yield.
Let's start with short incubation periods, between 1 and 6 hours. When symptoms start this quickly, we are dealing with preformed toxins, not bacterial invasion. The classic organisms here are Staphylococcus aureus and Bacillus cereus. The bacteria do not need to grow inside the gut. The toxin is already present in the food.
Next, we move to an incubation period of 8 to 16 hours. Here, toxins are produced inside the body after ingestion. The key organisms are Clostridium perfringens and again Bacillus cereus, but a different strain and mechanism than the earlier one.
Now, for 16 to 48 hours, we enter the territory of invasive organisms. These bacteria cause disease by invading intestinal tissue, leading to inflammation and sometimes bloody diarrhea. Important pathogens in this group include invasive E. coli, Salmonella, Shigella, Campylobacter jejuni, and Vibrio parahemolyticus.
Finally, with a broader incubation window of 12 to 72 hours, we see organisms that use both invasion and toxin production. This group includes Salmonella, Shigella, Vibrio species, Yersinia enterocolectica, ETEC, and EPEC.
So the key takeaway is this: very fast onset points to preformed toxins. Intermediate onset suggests toxins produced in vivo. Later onset raises concern for tissue invasion, with or without toxin production. Using incubation time helps you rapidly narrow the differential before labs even come back.
Whoa, that's a lot of bugs. So when do we actually send stool studies?
Only when indicated. That includes bloody diarrhea, severe illness or toxicity, immunocompromised patients, significant comorbidities, or situations where antibiotics are being considered.
And stool ova and parasite exams are usually not cost effective in acute diarrhea. Antigen tests are more useful. Fecal leukocytes are also associated with a bacterial cause in almost 90% of cases. What about endoscopy? Does it ever have a role here?
We usually order an endoscopy if we have prolonged symptoms or if we suspect IBD. Make sure not to confuse it with IBS, which a lot of medical students deal with because of stress. And I'm one of them, secret. In addition to IBD, we also consider performing endoscopy if we think we're dealing with C. diff or when we suspect ischemic colitis.
All that fluid loss must be alarming, no? Can we actually estimate fluid deficit in clinic itself?
That we can. We can break dehydration into 3 categories: minimal or no dehydration, mild to moderate dehydration, and severe dehydration. And the good thing is, you do not need labs to make this call.
An easy way to recall this is to remember the triplets Mimi, Moody, and Steven.
Mimi is a lovely girl. She's awake and alert and comfortable, chatting away. Her skin isn't dry, her hands are warm, her urine output is only slightly reduced. This is minimal or no dehydration.
Moody, the Discord mod who has drank too much Monster Energy drink and got diarrhea, is uncomfortable, restless, and tired. She chugs water and her heart rate is rapid. Her eyes look sunken, skin trigger is delayed, and her hands are cold. She only needs oral rehydration therapy and close monitoring, maybe even the Brad diet for a while: bananas, rice, applesauce, and toast.
Steven, he ain't doing too well. He's very lethargic, thready pulse, barely responsive. Interestingly, he's not too thirsty either. Skin turgor remains stented for more than 2 seconds. He needs immediate IV fluids.
We cover the more common acute diarrhea. Why don't we do a quick practice question before we move to the chronic?
A patient developed diarrhea after being admitted to the hospital and being treated with antibiotics. What is a causative agent? A. Clostridium difficile. B. Norovirus. C. Vibrio cholera. D. Giardia lamblia.
Definitely choice A, C. difficile. Remember, listeners, always trust your gut, except during diarrhea.
All right, now for chronic. It's a diagnostic problem, not an infection problem. It is defined as diarrhea lasting more than 4 weeks, and history is the most important part of the workup.
Walk us through the main categories.
There are 6 major categories: osmotic, secretory, inflammatory, motility disorders, fatty diarrhea, and factitious diarrhea.
Looks like we got our work cut off for us. Let's focus on osmotic versus secretory diarrhea, since that is exam gold.
Osmotic diarrhea occurs when poorly absorbed substances retain water in the intestinal lumen. It improves with fasting. Common causes include lactose intolerance, magnesium-containing antacids, laxative abuse, and carbohydrate malabsorption.
And secretory diarrhea?
Secretory diarrhea is typically large volume, often more than 1 liter per day, and it does not improve with fasting. Causes include infections, hormone-secreting tumors like vipomas or carcinoid tumors, bile acid malabsorption, and medications.
What about inflammatory diarrhea?
Inflammatory diarrhea results from mucosal injury, leading to blood, protein, or mucus outpouring. Think inflammatory bowel disease, microscopic colitis, chronic infections, or ischemia.
Another name for it is oxidative diarrhea. Those two names are actually used interchangeably. And fatty diarrhea?
Fatty diarrhea presents as bulky, greasy stools. Causes include pancreatic exocrine insufficiency, celiac disease, small intestinal bacterial overgrowth, and bile acid deficiency.
Evaluation is similar to that of acute. All right, let's do a quick review.
Keep it structured. Start with a detailed history, including onset, duration, nocturnal symptoms, and weight loss. Review medications and diet. Order targeted labs such as CBC, CRP, iron studies, and B12. Stool studies may include calprotectin, fat analysis, and electrolytes. Endoscopy is reserved for patients with red flags. Osmolar gap can also help us in diagnosis.
Let's now do a rapid fire round of management pearls.
Rehydration always comes first. Treat the underlying cause, not just the symptom. Correct nutritional deficiencies. Use loperamide only after infection has been ruled out. Antibiotics are reserved for specific indications.
Diarrhea, because patience is not an intestinal virtue. I'm also quite impatient, so let's do a quick question before we proceed. A 45-year-old woman presents with chronic watery diarrhea that persists during fasting. Stool osmotic gap is low, imaging is unremarkable. What is the most likely mechanism? A. Osmotic diarrhea. B. Inflammatory diarrhea. C. Secretory diarrhea. D. Fat malabsorption. And E. Irritable bowel syndrome.
The correct answer is C, secretory diarrhea. Large volume, no improvement with fasting, and a low osmotic gap.
All right, now that we've talked about diarrhea in general, let's zoom in on treatment, specifically antidiarrheal drugs. This is where pharmacology meets clinical judgment.
While antidiarrheals can provide symptomatic relief, they are not always appropriate. The goal is never to just stop the diarrhea blindly.
If you think about it, it's one of the ways our body tries to purge something bad out. So before we even touch medications, what are the main goals when treating diarrhea?
3 things. First, control fluid loss. Second, identify and treat the underlying cause. And third, provide symptomatic relief using antidiarrheal drugs when appropriate.
And that last part is where people get into trouble if they are not careful.
Antidiarrheal drugs are classified based on their mechanism of action. The main groups are anti-motility drugs, mainly opioids, antimuscarinic drugs, adsorbents and mucosal protectants, and anti-secretory agents like octreotide.
Let's start with the most commonly used group. Opioids always make people nervous. Why are they used in diarrhea?
Because they act as an agonist mu-opioid receptors in the gut. This leads to decreased propulsive contractions, delayed gastric emptying, reduced intestinal secretion, and increased fluid absorption.
So slower drug, drier stool.
Exactly. The main opioid antidiarrheals are morphine, codeine, diphenoxylate, and loperamide.
Loperamide is everywhere. Why is it so popular?
Because it is effective and relatively safe, loperamide does not readily cross the blood-brain barrier, so it has minimal central nervous system effects and low addiction potential.
And clinically, what do we use it for?
It is used for acute nonspecific diarrhea, traveler's diarrhea, irritable bowel syndrome, and chronic diarrhea associated with inflammatory bowel disease.
But there are situations where loperamide is a hard no.
Absolutely. It should not be used in bloody diarrhea, bacterial enterocolitis, acute exacerbations of ulcerative colitis, or situations where there is a risk of toxic megacolon.
What side effects should we watch out for?
The most common is constipation. Patients may also experience dizziness, nausea, and abdominal cramps. Rare but serious complications include paralytic ileus and toxic megacolon.
What about antimuscarinic like atropine?
They reduce propulsive contractions and decrease cholinergic secretions. However, their adverse effects are significant, including dry mouth, tachycardia, blurred vision, constipation, and urinary retention.
Which is why they are rarely used in practice.
Next up, adsorbents.
These include choline, pectin, activated charcoal, and bismuth subsalicylate. They work by absorbing bacterial toxins and protecting the gastrointestinal mucosa.
So they do not stop motility directly.
Correct. They mainly improve stool consistency and reduce toxin-mediated irritation. They are commonly used in traveler's diarrhea and mild bacterial infections.
Bismuth always feels underrated.
It has multiple actions. It absorbs bacterial toxins, has antimicrobial properties, and provides a protective coating to the gastrointestinal mucosa.
Which makes it a solid option, pun intended, for mild infectious diarrhea.
Now let's talk about the heavy hitter, octreotide.
Octreotide is a synthetic, long-acting analog of somatostatin. Somatostatin inhibits the secretion of many hormones and peptides, including gastrin, insulin, glucagon, and vasoactive intestinal peptide.
And how does that help with diarrhea?
Octreotide reduces intestinal and pancreatic fluid secretion, decreases gastrointestinal motility, and inhibits gallbladder contraction.
When do we actually use octreotide?
It is indicated for secretory diarrhea associated with carcinoid syndrome and AIDS. It is also used in growth hormone excess and in bleeding esophageal varices.
So this is not first line for simple acute diarrhea.
Definitely not.
Any downsides?
Yes, patients may experience nausea, diarrhea paradoxically, and gallstones formation due to reduced gallbladder contraction.
How about one final question to wrap this all up?
Two besties, Nour and Tala, are taking a girls' trip to Istanbul in the summer. It's on our bucket list, by the way, and Haya is included. They've recently listened to an awesome podcast episode on diarrhea and are worried they may get it during their travels, especially if they try those famous street oysters. They asked their doctor to prescribe them an agent for it. Which of the following would be effective? A. Omeprazole, B. Loperamide, C. Famotidine, D. Lorazepam.
Loperamide is the only drug in this set that has antidiarrheal activity. So B. I'd also recommend they get sunscreen too, even if it's tinted, girlies. Not because it prevents diarrhea, but because it prevents wrinkles.
Wow, Noor, that was a lot, huh?
Definitely. Let's go over some of the main points we chit-chatted about.
We started by reminding ourselves that diarrhea is a symptom, not a diagnosis. We defined it as increased stool frequency and liquidity, and emphasized that duration matters. Acute diarrhea lasts less than 2 weeks. Persistent lasts 2 to 4 weeks, and chronic diarrhea is anything beyond 4 weeks.
Then we broke down diarrhea by mechanism, which is the key to not getting overwhelmed.
Diarrhea happens when secretion exceeds absorption. And the 4 big mechanisms are secretory, osmotic, inflammatory, and abnormal motility.
We also learned how symptoms help localize the problem. Watery, large volume diarrhea with bloating points towards small bowel involvement, while frequent, painful, and low volume diarrhea with fever and blood points towards large bowel disease.
And if bugs are involved, incubation period is your best friend.
Very rapid onset, within 1 to 6 hours, suggests preformed toxins like Staph aureus and Bacillus cereus. Intermediate onset points towards toxins produced in vivo, like Clostridium perfringens. Later onset raises concerns for invasive organisms such as Salmonella, Shigella, Campylobacter, Vibrio, and pathogenic E. coli.
Osmotic gap seals the diagnosis.
An osmotic gap below 50 suggests secretory diarrhea. Above 125 suggests osmotic diarrhea. Intermediate values suggest mixed causes.
And to manage?
Rehydration is always first. Treat the underlying cause, correct nutritional deficiencies. Loperamide is useful but contraindicated in bloody diarrhea and severe colitis. Octreotide is reserved for specific secretory diarrheas.
And this wraps up today's episode of PodBites. Diarrhea truly is the one thing that really runs.
Thanks for tuning in. Stay healthy, stay hydrated, and eat a pear.
İstersen yak, savur, dağılır. بلي ما
اسكتي.
بلي بلي
اسكتي.
ماشي.
Something out bad.
بعدين معي I am sorry I don't speak in English. يعني شوفي ممكن يعملوا لنا بان من بود بايتس. ممكن حياة تعمل لنا بان من حياتها
ممكن
بصراحة.
الابيسود كلها.
ما حضرتي مسلسل قبل بيقول له واو وهيك literally
واو يا طلعت بس هيك طلعت واو